So it gives me great pleasure to introduce your speaker tonight. So Dr. Rob Rupp has been probably, 20 years? A little more? Yeah, I mean, he's been in Tahoe for a long time. He's one of our best orthopedic surgeons for the Tahoe Orthopedics and Sports Medicine group. He's also he's known for being a hip arthroscopist, which he's not talking about that tonight, but I just think it's important to know that before he became a hip arthroscopist, your options for hip surgery were pretty small, and they weren't great. So the fact that he's not only a hip arthroscopist, a shoulder specialist, a sports medicine professional, I mean, you're getting an expert here tonight to talk about shoulders. So I'm going to stop talking. I'm going to bring Dr. Rupp up, and please welcome him with a warm applause.
Thanks, Chris. Can you guys hear me okay back there? Okay.
You're good.
Maybe? So. Okay, so I'd like this to be very informal. If anybody has a question, they don't understand what I'm saying or what I'm trying to get at, go ahead, raise your hand. We have time after also to cover any questions, but like I said, I'd rather just, if someone's confused or has anything that needs clarified, just ask me, okay? So I'm going to do a broad kind of presentation of shoulder issues. You know, it's summertime and everybody's able to do a little bit more than what we do in the winter, which is, you know, ski and snowboard. Those definitely cause some shoulder injuries, but when we start adding events where we're using overhead activities with our shoulders, other things come into play. So this is going to be kind of a broad presentation. I'll hit on some treatment options also, and if anybody needs clarification, especially afterwards, if you don't want to introduce yourself to ask a question, I'll be around here afterwards if anybody wants to ask me any questions. So we could also label this talk, why does my shoulder hurt, or what can I do to avoid shoulder injury? So again, my goals are to review some of the anatomy of the shoulder so you guys know what we're talking about. In general, there's going to be a lot of orthopedic and bony terms, but that's just the descriptive nature of shoulder anatomy. Then we're going to look at some of the common causes of shoulder pain. I'll try to break them up into just kind of different locations of the shoulder and then outline some of the treatment options that you can go through. So again, starting with the anatomy, we're going to go with the bone structure. So if we look at some of the bone structures, the main ones of the shoulder are the humerus, and at the end of the humerus is the head or the ball. There's the clavicle, there's the scapula. If we look a little bit closer at the shoulder blade, which is the scapula, it comes together to form some bony prominences such as the acromion, the coracoid, and the glenoid. So the glenoid is the socket of the shoulder. So we have a ball and socket joint that is formed, and if we look at all the joints of the shoulder, again, joints are where bones come together and have movement. So if we look at the shoulder, there's the acromioclavicular joint, there's the glenohumeral joint, there's the scapulothoracic joint, and part of the shoulder girdle is the sternoclavicular joint, which is a little bit away from kind of the edge of the shoulder. So the main shoulder joint is actually the glenohumeral joint. So again, all these names are anatomic descriptions. So we're looking at the glenoid and the humeral head, so it's the glenohumeral joint. And again, a joint is where bones move together. So around the ends of the bone is a protective layer of cartilage called articular cartilage. So both the ball and the socket have an articular cartilage layer. The other interesting thing about the glenohumeral joint is it has a muscle tendon that goes right through it. So our biceps is two muscles. It's the long head and the short head, and one of those tendons goes right next to the humeral head and attaches at the top of the shoulder joint. So if we take away the ball and we look into the socket of the shoulder, we have the glenoid, and it's a pear-shaped bone. It's got a little bit of deepening with the labrum, which is a cartilage structure around it, and into that labrum there's multiple ligaments, and there's, again, the long head of the biceps tendon that inserts on that. These are all important structures that we'll go over in a little bit more detail later. The shoulder joint's interesting because unlike the hip joint, which is very constrained, a ball in a socket and there's a lot of bony stability, the glenohumeral joint is often compared to a golf ball on a tee. So this is an X-ray of a shoulder, and you can see the ball much larger than the small socket. So again, that's the comparison, and that's what gives us so much motion with our shoulder joint. If our joint was constrained, it would be very hard to have this kind of motion that our shoulder does enjoy. So what makes it stay together? And it's kind of a combination of muscle control and ligaments, which are soft tissue bands, to hold this unstable construct together. Another joint in the shoulder is the AC joint, or the acromioclavicular joint. So again, we're going to name things based on what bones come together, the acromion and the clavicle. So it's the acromioclavicular joint. If you just rub your hand on the top of your shoulder, kind of the ridge or the bump you feel, that's the AC joint. The scapulothoracic joint is the shoulder blade, and it moves on the rib cage. So it's very coordinated. If you look at this diagram here, as someone moves their arm, their ball and socket through range of motion, it requires your shoulder blade to rotate on the rib cage. And this is kind of an interesting analogy here, but it's so complex, it's very much like a seal trying to balance a ball. It has to move its head, its nose to balance that. So as I bring my arm up, it's not just the ball and socket moving, but the shoulder blade has to rotate in a way to balance the ball and socket. If that doesn't happen, then we have something like this part of the diagram where maybe the ball wants to come out of the socket. Why all this is coming up is because this is how complex our shoulder is. Just to bring my arm up is over 20 muscles that come into play involving the ball and socket and the scapulothoracic joint. Sternoclavicular joint is the bump we feel here. This is the medial border of the clavicle, and it has some articulation with the sternum. And some people come into the office and they have questions about this part of their shoulder also that we'll get to. So we've discussed the bones, now the muscles. So the main muscles deep in the shoulder that kind of are the weak link of the shoulder and cause so many people problems are collectively known as the rotator cuff. So along the shoulder blade, whether it's deep in the front or along the back, there's 4 muscles. The subscapularis is in front, and then in the back there's the supraspinatus, infraspinatus, and teres minor, and they all come together from red muscle that turns into white tendon that inserts at the edge of the ball, and it forms a cuff. And so that's why it's called the rotator cuff. And the rotator cuff is very important for how our shoulder works. If the rotator cuff doesn't work well, there's not a lot of stability to how the ball stays on the socket. So part of the function of the rotator cuff is to just center the ball on the socket while some of the bigger muscles that are more powerful, like the deltoid and the pectoralis, move our shoulder safely. If my rotator cuff isn't working well and I try to lift my shoulder up, sometimes it looks like this. So sometimes we see people with rotator cuff problems, and you can tell just by seeing what their shoulder does when they try to lift it. The ball just comes directly out of the joint because the rotator cuff doesn't control it. So this is a back view of the shoulder blade, and you can see the majority of the rotator cuff muscles and how they would pull the ball and hold it centered on the socket while we're using our shoulder through motion. The other major muscle in the shoulder joint, again, the long head of the biceps tendon, which comes from one of the biceps muscle bellies. Why this is important? Because a lot of people can have pain and injury in that part of their shoulder, and sometimes they wonder, why does my biceps ache? Why does the muscle ache down here? And it can be related to something in the shoulder with this relationship. So we've discussed the bones, the muscles, the major muscles in the shoulder. Then there's ligaments. So ligaments are bands of tissue that go from bone to bone. So as we see here, the ball and socket, again, the glenohumeral joint is held together with multiple bands of soft tissue. These are ligaments. And the other major relationship is the AC joint, and it's got multiple ligaments that hold it together also. Another structure that's a very common source of pain, but it's a normal structure, is the bursa. So a bursa is a cushion or a pad that our shoulder has under the acromion and above the rotator cuff. So on this diagram, it's this blue structure here. The shoulder blade also has some bursa. So when our shoulder blade is rotating over the rib cage, it's got these cushions. So many parts of our body have bursa. The tip of our elbow, the edge of our hip here, the front of our knee. Sometimes you see someone that impacts their elbow, they get a big swollen area. That's the bursitis. So if we take a normal bursa, which is a very thin layer of tissue, and often you can't feel it, but if it gets inflamed, it's a bursitis. So it becomes boggy and swollen. And when that happens in the shoulder, it gets even harder to move our shoulder up without pain because it's larger and things get pinched in the shoulder. So this is another potential source of injury or source of pain in the shoulder. So putting all this together, so for my shoulder to work normal and not hurt and to allow me to move and use it how I want, we've got to have these criteria. So we need full motion. And again, it's not just the ball and socket, but it's the shoulder blade rotating on the rib cage. We need joint stability from the ligaments. We need strong and balanced muscle control. And one thing that's kind of on its own is inflammation. So we need to have a shoulder that isn't inflamed, because sometimes all the anatomy can be normal, but we have inflammation in the shoulder and that can cause pain. So now I'd like to just review some of the things that can make a shoulder hurt. And if anybody's shoulder in the audience hurts, you kind of listen to what I'm describing, and if you need more information about it, just ask me at the end with questions. So we're going to hit a lot of different areas because a lot of different things can be a source of pain in the shoulder. So we'll start with the glenohumeral joint again, and one of the things that can happen is arthritis. So osteoarthritis is when that smooth layer of white cartilage that coats the ball and the socket starts to break down. And the problem is our body doesn't make new cartilage. That cartilage is a protective cover over the bone. And if it breaks down, then we have bone rubbing on bone, and that causes pain. Why do people get arthritis? Well, sometimes it's genetic. There's a component. Maybe the parents had wear and tear issues in their joints, so you might be prone. Sometimes we don't always know why it happens to some people more than other people. Sometimes a bad impact to a shoulder, like the cartilage will take an impact and it will set off a process that leads to post-traumatic arthritis. This is an x-ray of a normal looking shoulder. So we see the ball, we see the socket, and there's a nice space between those structures. That space is the cartilage that coats the end of the bone and protects it. This is a shoulder x-ray that looks like arthritis. So we have bone-on-bone appearance. And the other thing you might notice is we don't really have a ball shape anymore. The bone that is getting overloaded by pressure because it doesn't have cartilage starts to form extra bone. And these are bone spurs. As that happens, a shoulder not only hurts when you try to use it, but you can't move it as much. So we can't rotate, we can't get our hand behind our back, and partly because these bone spurs start kind of capturing the motion of the shoulder. The other thing that can happen in the glenohumeral joint, a lot of times to throwers, say you take your dog out, you've been waiting to play with your dog until the summer, it's been a long winter, and you start throwing the ball, and you throw really hard, and you feel something give in the shoulder. Well, sometimes people tear the attachment of the labrum or where the long head of the biceps attaches to that structure. So that can be called a slap tear. This stands for superior labrum, which is the top of the glenoid, where the labrum is, AP, or anterior to posterior. So the tear goes from the front to the back. And again, a lot of times people just can't throw anymore after that type of injury. So a lot of time people that do overhead or throwing sports or tennis, they might be affected by that type of injury. But by far and away, the most common thing that causes pain in the shoulder in terms of kind of the muscle structures, again, maybe a weak link in how we're built, is the rotator cuff muscles. So this is a rotator cuff tear. And again, the structure is such that we have red muscle fibers that come from the rotator cuff attachment and origin on the shoulder blade, they turn into white tendon fibers that insert on the bone. So usually, even though we kind of interchange muscle tear and rotator cuff tear, it's usually the white tendon that actually pulls off the bone. The problem is, once it pulls off the bone, there's nothing the body can do to get it reattached because the muscle's over here contracting, so once it comes off the bone, it really can't heal. One of the hallmarks of a rotator cuff injury is night pain. So a lot of people go, well, my shoulder's not great, but during the day it feels okay, I can use it. But at nighttime, I lay down, I try to sleep, and my shoulder starts hurting. And again, it just seems to be a hallmark of rotator cuff injuries. So this is something to consider if you have a lot of night pain with your shoulder injury. Another type of glenohumeral joint injury is a dislocation. So this is typically where ligaments that hold the ball and the socket together get torn. So now the ball can move away from the socket. And this is kind of interesting in that young people, if I'm a 20-year-old snowboarder and I fall and I dislocate my shoulder, 999 times out of 1,000 I've just torn ligaments. But as we get older, and if we dislocate our shoulder, so someone over the age of 50, if they dislocate their shoulder, they might have also torn their rotator cuff. So we have to start worrying about other types of injury based on someone's age and what happened. So if someone is a snowboarder or skier, maybe they're 60-some years old, they fall, they dislocate their shoulder, gets put back into place, the story's not over, because we have to check the muscles. Because what if your shoulder's back in place, but I can't get my arm up? Maybe the rotator cuff tore. So we have to be real careful when someone dislocates their shoulder, and if they're a little bit older, maybe they hurt some muscle and not just the ligament attachments. Another thing that can happen in the shoulder is sometimes people have no injury, and maybe they just notice over about a week span, they just start losing motion. And a term for that is a frozen shoulder. And what can happen is the normally loose ligaments or capsule of the shoulder, which should be very loose so that we have all this motion, they sometimes undergo a process of inflammation and they tighten. So we can use the term adhesive capsulitis, or we can talk about a frozen shoulder. And I'd say the vast majority of these are idiopathic, meaning it just can come on. Sometimes people that have had heart surgery, there's a little bit of an association, like months later, they go, oh yeah, I had a heart procedure and a couple months have gone by and now I can't move my shoulder that well. Or somebody that has diabetes, another association with people that sometimes develop a frozen shoulder. We're not really sure why that is, but again, it's something that can limit how the shoulder works. Another thing, again, is back to the subacromial space, so under the arch of the acromion bone, again, that bursa. A bursa is normal, but if it gets inflamed and boggy, it's a bursitis. And one thing that can kind of cause the whole thing is something that we refer to as shoulder impingement. So if I end up with some bone spurs under my acromion or from my AC joint, and if maybe my muscles aren't controlling the ball, keeping it centered on the socket when I bring my arm up, things might start pinching the bursa, and then we get the bursitis. Go ahead.
Is there a difference between the bursa and a tuberosity?
Yeah, so if we go into a little bit more detail of the anatomy of the humerus, the prominences are the tuberosities. So the greater tuberosity is a little bump here that's normal on the humerus bone, and that's where 3 of the rotator cuff muscles insert. The lesser tuberosity is deep in front, and that's where the subscapularis inserts. So anytime our bones have a bump, there's a name for it, and there's usually a muscle or tendon insertion. So that's what the tuberosities are, different than just a fluid-filled sac of bursa. The other issue that sometimes happens in the subacromial space is what is called a calcific tendonitis. So this is an x-ray of a shoulder, and everything that's this arrow is pointing at shouldn't be there. It's because the body, for some reason, has deposited calcium in part of the rotator cuff tendon. And it looks like that on an x-ray. We think maybe there's some injury in the rotator cuff tendon, but we're not really sure why the body decides to put calcium there. But this can be a source of significant pain. Someone just after maybe they overdid it, playing tennis or throwing a ball, a couple days later their shoulder starts hurting, then it gets severely painful, and we might get an x-ray and see that the body has deposited calcium. Again, just another interesting thing that can happen. The AC joints, the acromioclavicular joint, the term shoulder separation, someone takes a bad fall and the ligaments that hold the clavicle to the acromion, they tear, and so sometimes you see people in their clavicle sticking up. And it's because the ligaments that hold everything together tore when they fell. Different than a shoulder dislocation of the glenohumeral joint. Almost everybody over the age of 40 gets some arthritis of their AC joint. It's just the nature of how it's built. It just tends to break down. But for most people, luckily, it doesn't cause pain. But in some people, the arthritic process causes bone spurs to form, and especially on the undersurface, if they form, sometimes they contribute to that impingement. So this is another issue of potential pain in the shoulder. Some people move their arm around, they feel crunching and pain under the shoulder blade. This can be referred to as a snapping scapula. And again, just like the bursitis deeper in the glenohumeral joint, under the shoulder blade we have some bursa, and sometimes that gets inflamed and can cause catching and grinding of the shoulder blade. Some people come in, they say, how come I've got some swelling here? It doesn't really hurt, but I've got a bump. Well, again, this is another joint, and if there's any process of wear and tear, sometimes our bones form a little prominence. So if this bump doesn't bother you, it's okay. It's just a little wear and tear. Some people take a hard fall and can actually dislocate the clavicle there. Not as common as the AC joint separation, but it can happen here too. So if you take a hard fall and all of a sudden you notice things look different, that could have happened. So part of restoring shoulder function is looking at all those conditions I just outlined and seeing how they affect the normal function of the shoulder. So if we want to get back to our shoulder working, again, we have to restore the motion, the stability, have strong and balanced muscle control, and limit inflammation. So a lot of people ask me, they go, well, when should I come see the doctor? You know, my shoulder's been hurting. Do I need to come see you, or can it heal? Does it have a chance to heal on its own? So say you go out and you're doing something, you're kayaking, and you notice the next few days your shoulder starts to hurt. Well, maybe you just overdid it. So maybe a period of rest, let things try to calm down. Over-the-counter anti-inflammatory medicines, if your stomach's okay with ibuprofen or Aleve, or Tylenol as a pain medication. A period of colder heat, that can really help. And then if you feel like you're getting better, maybe you do gradual return. You don't go back 100%. I think if you give things 2-3 weeks to calm down, that's reasonable, but you got to be making progress. And if you're not able to move your shoulder, you got to be worried about something worse than just a strain or an overuse injury. So it's okay to give things some time, but if you have an injury and you can't lift your shoulder up, or it does something funny like this, you should come in sooner rather than later, okay? So what are other treatment options besides you doing things on your own? Well, injections are a great way to treat a lot of shoulder issues. So one option is a steroid injection. Now, people hear steroids in the news and they think they're going to build muscles. That's one type of steroid. But cortisone and the steroids for injections are just anti-inflammatory medicines, okay? So if someone has an inflamed bursa, sometimes a steroid injection into that boggy, swollen tissue will shrink it down to normal so it quits pinching. So that sometimes is curative for a bursitis in the shoulder. This diagram shows ultrasound. Sometimes we use ultrasound to help guide the needle placement in the shoulder. We can also inject around the long head of the biceps tendon. Sometimes it's inflamed and that will calm down. And if someone has a little arthritis in the shoulder, we can actually direct it into the shoulder joint and it can make it feel better. Some other types of injections, we use viscosupplementation or lubricant shots a lot for knee wear and tear issues, but we can also use them in other joints, including the shoulder. And sometimes people ask about PRP, platelet-rich plasma. It's kind of an interesting concept. If we take someone's blood, a certain number of cc's, we centrifuge it, we get a layer of platelets and other growth and healing factors. And if we inject that back to where maybe someone has an injury to their biceps tendon or their rotator cuff, if it's a partial thickness injury, maybe it will help it heal. So these get kind of exotic, but it's really based on what's going on in the shoulder. Physical therapy. So to get here, you passed one of the best therapy facilities in town. I mean, it's amazing what's going on downstairs. A lot of people ask, well, can I do things on my own? But I would just say in general you can, but anytime you have guidance, it's going to help with the therapist. Yeah?
Isn't the cortisone shot that you get just masking the problem? It's not going to fix it. Isn't it just masking it?
So the question is, again, is the cortisone going to help or just mask things? It depends on what the problem is. So if it's just an inflamed bursitis and maybe a little bit of overuse, sometimes we can take a swollen tissue and shrink it, and if it doesn't get swollen again, that solves the problem. But other things like arthritis or a tear, those won't get better with the steroid injection in terms of long term. So you're right. So certain conditions are I guess, curative. Other ones are just trying to help someone with their pain. So physical therapy, like I said, best if a therapist is involved, because again, you can look at YouTube, you can look at some of the slides I'm going to show, but until someone works with you and really shows you the correct way to do things and try to accomplish the goals of getting things balanced and loose, best for therapy involvement. But what can people do? So say I hurt my shoulder, I was playing baseball, next day I wake up, it's really sore, and again, I had that slide, restoring function. We want to let things calm down, we want to regain motion. So before we work on re-strengthening the shoulder, we want to get some motion. And one of the things we want to do is try to avoid aggravating the shoulder, which usually hurts when your arm comes up. So if I can do things where I'm leaning forward and gravity pulls my arm away from my body and I start moving it, that's a safe way to get some movement going. If I put it on the table in front of me and stretch a little bit, or if I use the wall and walk my fingers up the wall, I can start getting a little bit of motion without just taking the tender muscle and making it do all the work. As we get a little bit more complex with helping one shoulder work, we have options like using a rod or a wand or a stick, and one arm can help move the other arm into flexion, rotation. There's a variety of things that, like I said, therapy can help show people how to use another body part to help the injured area to regain motion. And then after you get a certain amount of motion that's comfortable, that's when you start worrying about re-strengthening or rebalancing the muscles. And in general, it's safest to work again on these muscles that involve no overhead activity or no shoulder level activity yet, but down here. So I can still work most of my rotator cuff with both internal and external rotation. There's a variety of ways to use a TheraBand, whether I'm internally or externally rotating and stretching, or say a weight or a dumbbell on my side, I'm gonna go against gravity, and then some other maneuvers to work on my shoulder blades. Once I'm comfortable down here, that's when it's a little bit safer to try to do things overhead, such as now I'm going to start progressing my arm above the shoulder level if I'm comfortable. So these are some things that you can do on your own if you're just trying to keep your shoulder function as optimal as possible. Say your shoulder doesn't even hurt, but you want to avoid having an injury. You're working on the rotation maneuvers of the rotator cuff and the strengthening of the supraspinatus, because again, they're going to help center the ball in the socket when we're doing all these other activities with different sports or different shoulder movements. So where does orthopedics come in? We do some injections, obviously, but if there's a major problem that our body can't heal, and sometimes you've tried therapy, medications, that's where we come in for definitive treatment. So our procedures are either arthroscopic, which is looking in the shoulder or any joint through little openings, including a camera, and then special instruments. But occasionally we still have to do open procedures like a shoulder replacement, which is kind of a bigger exposure. So what can we treat in the glenohumeral joint? So say someone has developed arthritis. Their shoulders, it just hurts them all the time. They can't really move. It's hard to sleep. Their motion is really restricted. The underlying problem is that the ball and the socket no longer have protection. Once that cartilage wears away, it's bone on bone. So we don't really have the technology to put new cartilage on the end of the bone, but we can put artificial surfaces on the ends of the bone. So if the ball and socket's arthritic, we can put a metal ball, we can put a polyethylene socket. So then when you move your shoulder around, it's no longer bone on bone. This is an X-ray example. Again, we've got joint space narrowing, we've got bone spur formation, and here's the X-ray solution. We've resurfaced the ball with metal, so now it's got a smooth covering over the bone, and we have a polyethylene, which you can't see on the X-ray, but it makes that space, it's like that, over the socket. Interesting, if someone has a really bad rotator cuff injury, like it's torn, it doesn't work anymore, we can still do a shoulder replacement. This is a standard shoulder replacement that works with the normal rotator cuff, so my arm can still come up. But if someone has no rotator cuff, their shoulder's arthritic, we still have options. This is called a reverse shoulder replacement. It's interesting, if we put a ball where the socket used to be and a socket where the ball used to be, it changes the dynamics of how the shoulder works. And if I need to lift my arm with the reverse shoulder replacement, all I need is my deltoid muscle. So I don't need a rotator cuff muscle anymore. So this has really kind of revolutionized shoulder replacement surgery over the past 10, 15 years in orthopedics. Now, what if my shoulder, acromioclavicular joint gets arthritis? Do I have to put a joint replacement in there? No, it's a small area. The interesting thing is we can get rid of the bone on bone by just removing about 1 centimeter of the end of the collarbone. And that decompresses the arthritis. There's no more bone on bone, and the pain goes away. Easy solution. Inflammatory conditions, I've already talked about bursitis. We can look in the shoulder, we can clean out the bursitis. Ideally, if we clean up bone spurs or other things that are causing the bursitis to have formed initially, the bursa comes back, which is a normal small cushion, but not the thickened bursitis. My scapula, my shoulder blade is grinding, I can't get relief with that. Same thing, it's kind of interesting, we can put someone prone on their stomach, put their arm in this chicken bone position, and actually do arthroscopy under the shoulder blade to clean out that bursitis. Calcific tendonitis, again, we don't always know why this happens, but someone's shoulder hurts a lot, they've got this big calcium deposit, we can look in the shoulder and direct a needle into that mass of calcium, and what's called a barbotage is inserting fluid, sucking it out. Inserting fluid, like washing it over and over again. And you can suck out the calcium and you can actually collect it in the syringe. If that doesn't seem to work, then we can always do shoulder arthroscopy. And when you look down at the rotator cuff, which is this picture, you can see a bulge typically, and if you make a little opening in it, out comes the calcium. It's interesting, the calcium isn't like a stone in there. It's like the consistency of toothpaste. So it kind of, you can press the edges and out come the calcium. And the pain is then improved dramatically. What if my shoulder won't move? The doctor says I've got a frozen shoulder, and I've gone to therapy and they've worked hard, but I just can't, it hurts too much to have them push on it. We've tried steroid shots, we've done other things. Sometimes we do a manipulation. So if we have someone go to sleep briefly under anesthesia, we can move the shoulder through full range of motion, and we're actually stretching out the ligaments. So if I'm doing that manipulation, I can feel the ligaments stretch and tear. We actually have to stretch them out so that they loosen up. If that doesn't work, we can do arthroscopy. This is the ball. This is the socket. There's tight ligaments that don't allow any movement of the shoulder. We can release those, and it kind of looks like that. And then again, the ligaments heal back, but they heal back a little bit lengthened, so we have movement. What if I dislocate my shoulder? So again, this is the glenoid, this is the socket, all the ligaments attached that hold the shoulder joint together. The most common area the ligaments tear off is at the kind of the bottom part of the glenoid, and that's called a Bankart lesion. So we just look in the shoulder, we find the ligaments that pulled off, and we reattach them with stitches back to the bone. The AC joint, I'm sure everybody has seen someone that their collarbone is sticking up here. Some people dramatically or amazingly have a shoulder that looks like that, and it works just fine. So you don't need surgery just because it looks funny, okay? But there are some people that have this injury, and when they try to use their shoulder, it hurts. It hurts right there. So in those cases, if it hurts, we can reconstruct. Like we can take a ligament that normally goes from the coracoid to the acromion and transfer it to the clavicle and back it up with some stitches. That's how we fix those. What if my biceps tendon is hurt? What if I have one of those slap tears? My biceps itself may look funny. Sometimes you see people, their biceps is wadded up, part of it here, looks different. They had that. So one of their biceps tendons gave, the long head biceps, and it wadded up down here, and a lot of people, just like the AC separation, they may do okay. Their arm looks kind of funny, but if it works, that's fine. Some people, though, it doesn't work well, and one of our options is to attach it to a different place. Where our normal anatomy attaches the biceps tendon is not really healthy. It doesn't have a good blood supply, so we don't try to repair it here if it's torn. We make a little opening in the humerus. We insert the biceps tendon. That's called the biceps tenodesis, and it heals there. And people do really well with that if they have biceps injury. So, rotator cuff, again, this is kind of the biggest problem we see overall that ends up needing surgery, I would say, because when the rotator cuff tears, the tendon pulls away from its attachment. And again, the body can't get it back out there. So what do we do as an orthopedic surgeon? Well, we insert an anchor where the tendon should be attached. That anchor can be all stitches, or it can be a composite material that turns into bone. We used to use metal, but we don't tend to use metal these days. But out of that little anchor come stitches, and we can weave those stitches through the torn tendon and attach that tendon back to where it was before it tore. And that's the only way it can get back to where it needs to heal. So that's the solution for a rotator cuff tear. So, a lot of different things I've talked about. And as you can see, we have different parts of the shoulder that can hurt, from bones to muscles to the joints. Some of the activities I discussed, trying to keep your rotator cuff strong, trying to keep your motion full, these are preventative and treatment options for a lot of these shoulder conditions. But if your shoulder just doesn't get better, if you can't move it especially, you should probably come in sooner rather than later to see for sure what's going on. So